Oh, it is the top of the hour. How about that? So let's go ahead and get started. I'm going to just take a second here and introduce Dr. Johnson. Let me stop this recording. So today's presenter is Dr. Taya Johnson. She is a triple board certified psychiatry and forensic psychiatry and child psychiatry. She is currently an assistant professor of medicine at the University of Texas at Tyler Health Science Center here in Tyler, where she treats children, adolescents, and young adults. Dr. Johnson also serves as the program director for the newly established Child and Adolescent Psychiatry Fellowship here at UT Tyler Health Science Center. She is also in the process of developing the new Forensic Psychiatry Fellowship here at the university. So you can imagine she is a pretty busy lady. So Dr. Johnson received her medical degree from the University of Louisville. She completed her adult psychiatry residency training at the University of Miami, her child and adolescent psychiatry fellowship at University of Louisville, and then her forensic psychiatry fellowship training at the University of Cincinnati. Her specialty interests include treating children, adolescents, young adults with various psychiatric illnesses, especially within minority populations, and conducting evaluations specifically related to forensic psychiatry. So I am going to pass the baton here over to Dr. Johnson and let her share her screen and start our presentation here. Dr. Johnson? I know she's here. I still have you on mute, Dr. Johnson. We'll just hang out here for just a second. She may be having some technical difficulties. So while we're waiting, Dr. Johnson's joining us here. I wanted to let you know that if you are not familiar with the Child and Perinatal Psychiatry Access Network and you are a primary care provider here in Texas, we would love to tell you more about that. Child Psychiatry Access Network has expanded into the perinatal space. I think of it as a public health nurse, I think of it as working upstream so that we can prevent some of the mental health conditions in our children. And now I see Dr. Johnson, and I'm sure she's working on getting her slides up right now. If one of my team members would put the phone number in the chat, please, the toll-free number. If you're in Northeast Texas, you will contact us here in Northeast Texas, but I suspect we've got folks from across the state. You can call that toll-free number and ask for the hub in your region, and we'll get you connected with the right folks to tell you more about the Child Psychiatry Access Network and the Perinatal Psychiatry Access Network. All right, looks like we've got some screen coming up here. We're working on it right now. Yep, looks good, Dr. Johnson.
Oh, it's the right, you're seeing the right thing?
Absolutely, yes, ma'am.
Okay, perfect. And you ready for me to start, Laura? I'm sorry.
Yes, ma'am, you can start.
All right, perfect. Well, good afternoon, everyone. I am Dr. Taya Johnson, presenting this CPAN presentation on clinical pearls, trauma assessment and diagnosis in pediatric primary care. This is not meant to be a exhaustive telling you how to treat and can I turn these notifications off because that's gonna get on my nerves. I don't know how to do that. But this is not a comprehensive telling you how to treat trauma and diagnose trauma within your primary care setting, but it's just to keep something in the back of you all's minds as you all are seeing patients in primary care settings to keep to think about so that you don't forget about this piece, because I feel and data shows that a lot of times we may not always think about trauma being a possible reason for what you are seeing in your patients. And so just want you all to think about it, put it in front of your mind instead of it staying in the back of you all's minds. So with that, at the end of this presentation for our goals and objectives, you all should be able to identify the signs and symptoms required to appropriately diagnose trauma and related disorders in children and adolescents. I will provide with you all with examples of how to screen and assess for trauma and related disorders in children and adolescents, and then describe different treatment options to consider when treating children and adolescents with trauma and related disorders. So let's talk about the prevalence of trauma first. More than 2/3 of children report experiencing at least one traumatic event by 16 years of age. And in 2015, the national average for child abuse and neglect victims was 9.2 victims per 1,000 children. Also, 25% of high school students report involvement in at least one physical fight at school. 20% of high school students report a history of being bullied, and 1 in 6 say that they were actually cyberbullied. 19% of those injured, so children who are injured, or 12% of those who are physically ill will have post-traumatic stress disorder just from their injuries and or the consequences of being physically ill and just having trauma associated with that. And then over half the families in the US have been affected by some type of disaster. So trauma is very common. A lot of folks, kids, adults included, have experienced some type of trauma. So what is trauma? What do we mean when we're talking about trauma? Trauma is defined as a significant event or experience that causes or threatens harm to one's emotional and or physical well-being. So what are some examples of traumatic events? We're talking about psychological, or emotional, physical, or sexual abuse, which people think of that a lot of the times when they're thinking of trauma. But there's also other forms of trauma: community or school violence, witnessing or experiencing domestic violence, um, being involved in national disasters or terrorism, commercial sexual exploitation or sex trafficking victims, sudden or violent loss of a loved one, refugee or war experiences, military related stressors such as deployment or parental loss or injury, physical or sexual assault, neglect, and then serious accidents or life-threatening illnesses. Now, of course, these are just examples of trauma, and this is not extensive whatsoever. But just letting you know, multiple things can be trauma. And some people even like to think of it like big T, so big T trauma and little T trauma, whereas little T trauma may be, like divorce from families, like parental divorce or some kind of situation like that, or big T traumatic events would be those listed on this slide. So how does trauma affect the developing brain? Because there is research that shows us that trauma can impact every brain system and brain area. It shows that childhood trauma alters the neural pathways involved in mediating the stress response. And these alterations can lead to psychiatric, behavioral, and functional issues that cause patients and families to present to providers for help. So I want you all to think about that. Trauma can affect those brain chemistries, those neural systems, and then there will be the effects of psychiatric, behavioral, or functional issues. So again, when a lot of times when we see kids coming in with behavioral health problems, we don't automatically think about trauma. We in general, the community, don't think about trauma affecting those children and causing those issues. But that is something, again, by you all attending this presentation, I want you all to think about. And there are symptoms that can mimic several different psychiatric diagnoses that actually come from the trauma instead of from whatever psychiatric diagnosis that might be in the forefront of your mind. And we'll get into that a little bit more later. So not all children who have traumatic experiences will develop symptoms. Thankfully, that is the good news about trauma. Some children will have few or no symptoms of traumatic stress. Some will have symptoms that diminish over several weeks, and then some may have long-lasting emotional, behavioral, and cognitive difficulties that affect multiple domains of life as a result of those experiences. So let's do a case presentation that we'll talk about throughout this. And so for this part, I want you all to either unmute your mics to answer or type in the chat, and I'll pull up the chat on my end so I can see what you all are typing, to answer what we think might be going on with little Johnny. So little Johnny is a 6-year-old male who presents to the pediatrician's office for a mental health visit. Mom reports that for the last month and a half, he has been more irritable and angry, constantly, quote, on the move, end quote, is not sleeping well, has trouble concentrating at home, and does not seem to listen. His teachers have seen similar behavior over the same time period. Without any other information, what additional questions would you all like to ask to assist with this case? So what would you all ask the mom or the kid in this case? Okay, any recent stressors at home? Yes, good, great question. Any changes at home? Any changes in home life? Yes. What else? Have there been any changes? Oh, I already read that one. New people in the child's life? Good question. Changes at school? Yes.
Any concerns about bullying or just like abuse in general?
Any about bullying or abuse as well? Right. And I know this talk is specific to trauma, so you all are thinking about trauma stuff, but I want you all to think about other things too. So someone said any new medications or changes to medication. Great question. Recent exposure to events or media. Great question. What else? Sleep patterns. Okay. What else? Any similar pattern or outbursts in the past? Great question. Yes. Any other comments or questions that you all want to ask for this case? Any mental health history in the family? Academic difficulties? Yes. All right, so no one else is typing in the chat. So we're going to come back to this case. So I want you all to be thinking of questions to ask. Thoughts of suicide, great question. I want you all to keep thinking of things. You all can keep typing in the chat and we'll come back to this case in a minute. But I want you all to think about, remember this case of little Johnny is him being 6 years old, and think about this and we'll come back to it. So think about other questions, and if they come up, just type them in the chat and I'll read them when we get back to little Johnny's case. All right, and so I want to start off by presenting the clinical presentation of post-traumatic stress disorder to you all. And the reason why I'm talking specifically about post-traumatic stress disorder, even though this presentation is titled Trauma and Assessment and Diagnosis in General, if we think about PTSD and the specific criteria of PTSD, knowing what the criteria for PTSD is in your mind, then you will be able to say, even though this child may not have all of the symptoms of PTSD, they have several symptoms. So they are at least got some kind of trauma or stressor related disorder, because that is a category within the DSM if someone doesn't meet full criteria for PTSD. But we're going to talk about the full criteria, DSM-5 full criteria for PTSD. Because like I said, if you know what PTSD is supposed to have, then if a child has a little less than what PTSD calls for, you can still give them a trauma diagnosis because you know that they at least have some pieces of trauma at play in their case. Okay. And so the DSM-5 criteria for patients ages 6 and older, we're going to go through those, but there's also criteria from 6 and younger, and we'll discuss those as well as we go through each of the symptoms. So first and foremost, they have to have, for both age groups, 6 and older or 6 and younger, have to have exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways. They either have to directly experience a traumatic event, witnessing in person the event as it occurred to others, learning that the traumatic events occurred to a close friend, a close family member, or close friend. In cases of actual or threatened death of a family member or friend, the events must have been violent or accidental. And then experiencing repeated or extreme exposure to adverse details of the traumatic event or events. So for 6 and older, that would be like first responders collecting human remains, police officers repeatedly exposed to details of child abuse. But the experiencing repeated or extreme exposure to adverse details of the events does not apply to exposure via technology or pictures unless it is work related. So because we're dealing with children and adolescents, more than likely they're not going to have work related exposure through technology or pictures. So that's not going to apply in this situation when we're talking about kids. So if we're thinking about video games and things of that nature, or even just seeing it on the news or social media, according to DSM-5, that doesn't fully meet the criteria for the exposure to actual or threatened death, serious injury, or sexual violence. Now, for kids 6 and younger, they have the same criteria, but when it comes to they need to either directly experience it, witness it as it occurs to others, especially primary caregivers. They add that, especially primary caregivers, in that. And then also learning that the event happened to a parent or caregiver. Whereas for the 6 and older, it can be learned that it occurred to close family members or friends. But for 6 and younger, it has to be learned that it happened to a parent or a primary caregiver. Now, first is there must be, so after experiencing an event, first you have to experience an event. Next is you have to have the presence of one or more intrusive symptoms associated with the traumatic events. So you either have to have recurrent involuntary and intrusive distressing memories of the traumatic event. In children older than 6, that you may see that in repetitive play, and see that in their themes of their play when they're playing. And then younger than 6, spontaneous and intrusive memories may not appear distressing. So they might just talk about it in general, but not seem upset about it. And they may also express them as play reenactment. And so they may just be very laissez-faire, or, just kind of nonchalant about it and just can speak of it freely, but they're always talking about it. But they might not be upset with what they're talking about. So just because they're not upset doesn't mean that it's not traumatic and it's not meeting criteria for them to have PTSD or any other trauma and stressor related disorder in kids younger than 6. They also have to have recurrent distressing dreams in which the content and or affect of the dream are related to the traumatic events. In children, there might be frightening dreams without recognizable content. So they can just say they had a nightmare or they had a scary dream, but it doesn't necessarily have to be a dream of the traumatic event in children. And then in younger than 6, you might not be able to ascertain the frightening content is related to a traumatic event at all. They just might say that they didn't sleep well, or they're scared to go to sleep or something like that in a child younger than 6. So you may not be able to even figure out what they're dreaming about at all. But if they suddenly start having trouble with going to sleep, or they're afraid of sleep, or saying that they're afraid to sleep, then we need to have our light bulbs on, thinking that there might be some kind of this might be related to some kind of trauma, especially if they experience some kind of trauma. There can be dissociative reactions, such as flashbacks in which the individual feels or acts as if the traumatic event were recurring. In children, again, this may be reenacted in play. So they may reenact the trauma, the event in play with their toys, and that's them basically having like a flashback, instead of the traditional flashbacks where we think about an adult kind of going back in their mind, feeling like they're right back in the moment. The kids may not be able to express that, but they will be showing it in their play. If every time they, play with their toy cars and they're always having an accident, and you know that they were in a major accident, that should be a light bulb that goes off. Having intense or prolonged psychological distress at exposure to internal or external cues that symbolize or resemble an aspect of the trauma. So anything, them having any kind of behavioral reaction or showing some kind of distress when there's something that reminds them of that traumatic event, that's a symptom. And then also having marked physiologic reactions to internal or external cues that symbolize or resemble an aspect of traumatic events. So if you notice, they have an increased heart rate when we're talking about kids, physically ill kids that develop PTSD. So maybe the kid has elevated heart rate every time they come to the doctor's office because of the trauma that they've experienced, having multiple hospitalizations or something like that. So you may see the physiologic reaction of that trauma in their vital signs. So in addition to having intrusive symptoms, there also has to be a persistent avoidance of stimuli associated with the traumatic events, as evidenced by one or both. So they either need to have avoidance of or efforts to avoid distressing memories, thoughts, or feelings about or closely associated with the traumatic events. And then they need to have, or they can have, can have avoidance of or efforts to avoid external reminders that arouse distressing memories, thoughts, or feelings about or closely associated with the traumatic events. So if there's a kid that you're talking to them and they say, you ask them what happened and they say, I don't want to talk about it. I don't want to talk about it. I don't want to think about it. I don't want to remember that. I try not to remember that. Those are hints or are clues that they're trying to avoid the memories and thoughts and feelings, associated with that. So they don't want to bring it up. Or you can have it to where, maybe they don't ever, like, say they got in a car accident in front of the playground that they used to like to play it, and now they just go out of it. If they see their car driving in the direction of going towards that park, they are having a fit. They're having tantrums because they're trying to not think about, they're trying to avoid it. They're trying to, hopefully through their tantrum, get their parents' attention or the caregiver's attention to go a different way so that they don't have those memories come back because they're going to drive past the park. They also have to have negative alterations in cognitions and mood associated with the traumatic events, as evidenced by two or more of the following. And this is important because a lot of times people, all of us as providers, we forget that there is an emotional piece attached to having trauma. So not only do you have these, avoidance symptoms, these intrusive memories and thoughts, but there's also a piece of where your emotions, your cognition, there's going to be a change in your mood. There is a change in mood associated with it as well. And sometimes people forget that piece. And so when they're thinking about, when they're evaluating a kid who or seeing a kid and they, just kind of complain of nightmares and, kind of complain of not wanting to think about something, but they have strong, negative moods, we might miss the point that this could be trauma related and not just depression or, some other kind of mood disorder. So those symptoms include the inability to remember an important aspect of the traumatic events, usually due to dissociative amnesia. So just completely unable to recall certain aspects. They can't even tell you about it. Persistent and exaggerated negative beliefs or expectations about oneself or the world. So they just are down on themselves, feel guilty. They have a negative self image, persistent distorted cognitions about the cause or consequences of the events that led to the individual to blame his or herself and feel guilty, persistent negative emotional states, so feeling guilt, horror, anger, shame, just constantly in a negative emotional state. They can also have markedly diminished interest or participation in significant activities. And this is very similar to what we see in depression. And so, not knowing, if we don't ask about a child having exposure to traumatic events, we can easily misdiagnose the kid with depression because we didn't ask about any trauma, because the markedly diminished interest or participation in significant events, that is a sign of depression as well. Another symptom could be feelings of detachment or estrangement from others. So just feeling alone and isolated and feeling like no one understands you. And then a persistent inability to experience positive emotions. So unable to feel happiness, satisfaction, or loving feelings. A lot of times you will hear folks who have severe PTSD, they'll just say, nothing makes me happy. I can't be happy. And again, if you don't ask about the trauma, you could miss this, because this sounds like, what we used to call dysthymic disorder, which is now persistent depressive disorder, or something along those lines, by completely missing the trauma because we didn't ask about it. Now, in a kid, so this is all for kids 6 and older. In a kid younger than 6, they can have either avoidance of stimuli or negative alteration in cognition, mood associated with the event. Whereas for older children, we said they need to have intrusive symptoms, avoidant symptoms, and negative alterations in cognition or mood. Younger children can either have the avoidance of stimuli, or they can have negative alterations in cognition and mood. So they don't have to have both if they're younger than 6. And so in those younger than 6, the persistent avoidance of stimuli would look like avoidance of or efforts to avoid activities, places, or physical reminders that arouse recollections of the traumatic event, avoidance of or efforts to avoid people, conversations, or interpersonal situations that arouse recollections of the traumatic event. And then in a child 6 and younger, the negative alterations of cognition can look like substantially increased frequency of negative emotional states, markedly diminished interest or participation in significant activities, including constriction of play. So maybe they're not playing as much as they used to anymore. Socially withdrawn behavior, which, looking at this, we have to be careful, because a child could be, let's just say, they're noticed that there's a decline in interacting with others. And so you might go down a path of thinking this might be autism related, but if you never ask questions about trauma, you can miss why the child has become socially withdrawn, and especially in a child younger than 6. And then also a persistent reduction in expression of positive emotions. So the child is just not happy. We also have to have marked alterations in arousal and reactivity associated with the traumatic events, as evidenced by 2 or more of the following. So irritable behavior and angry outbursts with little or no provocation, typically expressed as verbal or physical aggression towards people or objects. So many times we have kids that present to pediatric offices, and even to mental health offices, where the kid is irritable and angry, and we completely miss asking about trauma and go along the lines of DMDD or ADHD or even depression. But this component of irritability and angry outbursts with little or no provocation, we need to make sure when we see that, okay, let me make sure I ask about trauma as well. And those younger than 6, they can have extreme temper tantrums. So that's what it can look like in younger than 6. Um, Reckless or self-destructive behavior. This is not a symptom to look for in younger than 6 years old. Hypervigilance is a symptom for all ages. Exaggerated startle response for all ages. Problems with concentration for all ages. And then sleep disturbances, difficulty falling asleep, staying asleep, or restless sleep. And that applies to all ages as well. And so, as you can see here, problems with concentration, that's a symptom of depression. Problems with concentration is a symptom of ADHD. if we don't ask about trauma, we can easily miss diagnosing a kid with trauma. So again, we need to make sure that we bring asking about trauma to the forefront of our minds and not keeping it in the back of our minds so that we don't misdiagnose children or in adolescents. All right, so what are other diagnostic criteria? So the duration of the symptoms has to be more than 1 month after the traumatic event. So anything less than 1 month of the traumatic event is called an acute stress reaction. But if these symptoms last beyond a month after the event, then you can start looking into diagnosing post-traumatic stress disorder. The disturbance should cause clinically significant distress or impairment in social, occupational, or other important areas of functioning, and it's not attributable to physiological effects of a substance, such as medication, alcohol, or drugs, or another medical condition. And so clinical pearls that I want to talk about. Most kids are not going to always meet the criteria for a PTSD diagnosis, but they have significant functional impairment from experiencing a trauma. And in those cases, you can diagnose the patient with unspecified trauma and related trauma and stressor related disorder, but still follow the treatment recommendations for PTSD in those kids, because if we want to make sure that we have all the criteria met and we're missing, 1 or 2 things here or there out of the criteria, it's okay to just diagnose them with unspecified trauma and stress-related disorder and still follow the treatment guidelines for PTSD. Because a lot of times the children are not going to meet the full PTSD diagnosis, but they got the trauma, a significant trauma, and they got a lot of behavioral issues and functional impairment that happened temporally after that trauma. So therefore, following the treatment recommendations for PTSD is appropriate in those cases. All right, so when we're talking about thinking about trauma and PTSD, we got to do a differential diagnosis, which is some of what I was doing as I was going through the criteria for PTSD. So ADHD is a major differential major player in our differential diagnosis, because with PTSD there is restlessness, hyperactivity, disorganized and or agitated activity or play. There's difficulty sleeping, poor concentration, and hypervigilant motor activity. So they're always on the go, always on the move. And there's like I said before, there's a lot of overlap between PTSD and ADHD. And so to help us tease that out, because again, just because a kid has the trauma and has symptoms of PTSD doesn't mean they can't have ADHD either. They can have both together. They can travel together and be concurrent diagnoses. However, we need to make sure, this is a clinical pearl, make sure to get a careful history of the trauma exposure and the timing of the symptom onset or the worsening of symptoms to help distinguish PTSD from ADHD. So if a kid never had any symptoms and then a trauma happens and then they have all these symptoms after trauma, more than likely that's PTSD. Otherwise, if there's a kid, they've kind of had some symptoms, but they experienced a trauma and then the symptoms got worse. Okay, now this may be a concurrent PTSD and ADHD picture, but we need to have that careful history and asking for the timing of symptoms to help us tease that out. And sometimes it's difficult to do because parents don't always remember. So do the best that you can. And sometimes, if you think it's ADHD and you start treating down ADHD and it's not getting better, you might need to reevaluate your diagnosis and trying different treatment protocols, treatment recommendations, because maybe it was not the correct diagnosis, but the parent, was not able to give you the details that you needed to make the correct diagnosis at first. Oppositional defiant disorder is on the differential for PTSD and symptoms that look like PTSD or others. And so in oppositional defiant disorder, there's angry outbursts and irritability. And so again, PTSD has a predominance of those symptoms, which can also present in oppositional defiant disorder. So is this a PTSD versus is this the ODD? And actually it can be together again. It can be a PTSD and an oppositional defiant. Sometimes the kid is oppositional and defiant because of the trauma that they went through. And so them trying to avoid those intrusive thoughts and memories is what's making them be defiant, and therefore they're getting a diagnosis of oppositional defiant disorder as well. So we have to watch that. Panic disorder is on the differential because you can have elevated anxiety and physiologic and psychological distress associated with it, which PTSD does have. So we have to make sure we rule that out. Other anxiety disorders such as social anxiety disorder, OCD, generalized anxiety disorder, or phobia, there's going to be avoidance of the feared stimuli. There's going to be hyperarousal when exposed to the feared stimuli. There's going to be sleep issues. There's going to be hypervigilance. There's going to be an increased startle reaction. Again, all of that is part of PTSD as well. So we have to tease out what is causing those symptoms. So if this is a phobia, you know it's going to be one specific stimuli that's causing all of this. Social anxiety is going to be social situations cause these symptoms. But again, we still need to make sure that there is no trauma in those kids who have those symptoms. Major depressive disorder, as I brought up, there can be social withdrawal, affective numbing, sleep difficulties, and self-injurious behaviors in both PTSD and major depressive disorder. So we have to rule out both of them, or rule in both, because they both look similar. With bipolar disorder, you can have hypomania, aggressive, or hypersexual behavior, and so we have to be careful. This is a clinical pearl. The hyperarousal symptoms and the anxiety symptoms associated with PTSD can be misdiagnosed as hypomania. So if someone is constantly on edge, constantly, watching their surroundings, they are not sleeping well, going, days without sleeping, that can look like bipolar disorder. And it can be, again, if trauma is not asked, or we don't ask about the trauma that's been experienced, we can miss it and maybe diagnose them with a bipolar disorder instead of diagnosing them with PTSD. And then the traumatic reenactment may be misinterpreted as aggressive or hypersexual behavior, which is associated with hypomania or mania, because there is a hypersexual component in mania and hypomania. And so if their traumatic event was sexual assault or sexual abuse, and that's what they're reenacting, that can be misdiagnosed as being hypersexual from bipolar disorder instead of being a reenactment of the trauma that they experienced. So we have to be careful with that. Also, psychotic disorders can be on our differential. Severe hypervigilance, flashbacks, sleep disturbances, numbing, and or social withdrawal of PTSD can mimic psychosis. And then having hallucinations and perceptual disturbances can be present in both situations. And a clinical pearl with this is that children with PTSD may have unusual perceptions that should be made to be differentiated from hallucinations of psychotic disorders, because a lot of times we get referrals here that there'll be, a kid has reported hallucinations. 8-9-year-old kid reports hallucinations, and come to find out that kid has some trauma that has caused them to have some unusual perceptions that are not true hallucinations. And so just because a child is reporting hallucinations doesn't necessarily mean that they are psychotic. That with psychosis, with psychotic disorders, there's other evidence of other things that makes them psychotic, such as delusional thought content, disorganized thought or speech. So it's not just the presence of hallucinations means it's a psychotic disorder. And that's the same. That's what we need to make sure we keep aware of in children with PTSD. They will report hallucinations, but that doesn't mean that they're psychotic. And I think a lot of times when primary care providers get a kid who's complaining of hallucinations, it's like, oh my goodness, this kid must be psychotic. And if they're, having a clear thought process, talk very clearly, not being disorganized in speech or thought, don't have delusions or anything like that, more than likely this is going to be related to some kind of trauma that they've experienced, and it's some kind of trauma reaction and not them being psychotic. Because especially young children who report hallucinations, childhood onset schizophrenia is very, 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 very rare. And so if that child is truly schizophrenic or has schizophrenia, childhood onset schizophrenia, that child probably needs to be evaluated by, a first episode psychosis clinic at a, at like a Cleveland clinic or a Mayo clinic or John Hopkins or something like that, because it's so rare that there's not that many cases. So they would want to study that to add to the research and the literature related to childhood onset schizophrenia. So that's something that needs to be considered, because I have seen quite a bit coming from primary care providers. The kid will report hallucinations, primary care provider puts them on an antipsychotic, and that wasn't needed to begin with. That's not even, proper treatment for that. So psychotic disorders can be a part of the differential, but just because the presence of hallucinations is there does not mean that the kid is actually psychotic. And then there's primary substance use disorders that is part of the differential as well. Drugs and or alcohol can be used to numb or avoid trauma reminders. And a lot of times people actually say that the gateway drug is actually trauma. I've heard that told a lot of times with kids, adults, teenagers get into using substances because they first experienced trauma and they're trying to avoid that. And so trying to avoid trauma, it could lead to them having substance use disorders, but also them using substances can have them become numb and have behavioral differences that look like PTSD, but could just be because they're using substances. This slide, probably can't read it very well, but it's just to show that there's a lot of symptoms that look alike and can be diagnosed as multiple different things when you see these symptoms. So it's not, so that's why we as providers, we have to not just think, oh, when I hear this one word, that means that. So for example, when I hear trouble focusing, that means ADHD. We can't do that, because trouble focusing could be multiple things, such as ADHD, trauma, anxiety, depression. It could be a list of things. So we need to make sure that we don't just pick one symptom and think that that means one specific diagnosis, because there's a lot of overlap. And this is a clinical pro. So there was a study done with, I believe it's the state of Michigan. They have a program similar to our CPAN program. They have one in the state of Michigan as well. And they did research and they found that PCPs are more likely to diagnose patients less than 11 years old with ADHD than with trauma, and that PCPs are more likely to diagnose patients 12 and older with anxiety and depression than PTSD and trauma. And the reason for that is because they didn't even screen or assess for PTSD or trauma in the primary care setting. So this is what I want you all to think about, because it can, again, there's so much overlap. You can easily misdiagnose a child with either anxiety, depression, or ADHD, depending on the age, if you don't ask for or ask about traumatic experiences. And this slide is just to show how much overlap there is between ADHD and trauma. The difficulty concentrating and learning in school, easily distracted, often doesn't seem to listen, the disorganization, the hyperactivity, the restlessness, the difficulty sleeping. If you see this, most of the time, according to that research, a primary care provider is going to say, oh, that's ADHD. But that could be trauma if you don't ask for and assess for trauma as well. So again, this presentation is to help you all put trauma in the forefront and not in the back of you all's minds. So when it comes to screening and assessment, first and foremost, screening is recommended during the first mental health assessment visit. So whenever the kid is coming to see you all in the primary care office for a mental health reason, you should screen for trauma. Routinely ask about traumatic events. Even if the trauma is not the reason for the first visit, routinely ask children about their exposure to traumatic events, or ask the parents, ask both of them. A clinical pearl for this is that the main reason to screen for trauma at all mental health visits is to make sure that the emotions or behavioral concerns that they are presenting to you with would not be better explained by a trauma reaction, thus warranting a different treatment approach. You need to make sure that you ask about adverse childhood experiences, or ACEs. So there are screening tools for that. There's one called the PEARLS, or the Pediatric ACEs and Related Life Events Screener. There are parent and child forms of this screening tool, and it's for ages 0 to 19. Now, a lot of people use the ACEs screen in their offices, which is okay. However, the original ACE questionnaire is intended for use with adults 18 and over. And so the pediatric one, the PEARLS, is much better to screen for trauma in children. And so if they endorse exposure to traumatic events, then you want to screen for PTSD symptoms if the PEARLS is positive. And so when they are getting exposure, if they've endorsed exposure to traumatic events, then you want to then screen for PTSD, and there's multiple screenings for that. There's a juvenile victimization questionnaire that has been validated for diverse samples of children ages 2 to 17. The children 7 years of age and older can self-report trauma and trauma exposure and symptoms. And a clinical pearl for this is that you need to get information from multiple informants, especially in prepubertal children, to improve diagnostic accuracy. One of my favorites that I use a lot is the Child PTSD Symptom Scale for DSM-5, or the CPSS-5. It is valid and reliable self-report instrument for assessing DSM-5 PTSD diagnosis and severity for children and adolescents ages 8 to 18. And it's just a real quick, easy answer. And then depending on how high their number is, you can see how severe their symptoms are, and that they meet the criteria for PTSD. There is a trauma symptom checklist for young children for use in children 7 and younger. It's not a free checklist to use, but it's just important for you all to know that it exists. Now, if you wanted to offset the fact that requires a fee to get that checklist, research has shown that there are positive responses to 15 symptoms on the child behavior checklist preschool version, which is free, that correlate with the positive screen for PTSD. And so you can correlate that with the positive history of trauma exposure and then kind of put it together in that way. But the trauma symptom checklist kind of is doing it all for you in one concise checklist versus trying to look at the child behavior checklist preschool version, picking out the ones that are related to PTSD and then correlating that with a history of trauma exposure. So that just makes it a little bit difficult. All right, so now we're back to little Johnny. So little Johnny is a 7-year-old male who presents to the pediatrician's office for a mental health visit. Mom reports that for the last month and a half, he has been more irritable and angry, constantly on the move, is not sleeping well, has trouble concentrating at home, does not seem to listen. His teachers have seen similar behavior over the same time period. Prior to this time period, little Johnny was a good boy and never caused trouble. So what additional questions will we like to ask now that you all have heard this presentation? Anything else that you all want to add? You all had some good stuff prior to, but there's anything else that you all want to add? And you can type it in the chat or unmute yourself and say it. Are there nightmares? Okay, good. What else? Are there certain people or places around whom or which his behavior worsens? Good. That's a good one. What else? Okay, no one saying anything else. What is our differential diagnosis for little Johnny? Okay, good. Any people, places Johnny has been away from where something could have happened? Who does he live with? Yes. what are you all thinking is on your differential diagnosis for little Johnny as of right now without any more information? Has he been avoiding anything he used to enjoy? Good. You can also type in or unmute yourself for what would be on your differential diagnosis at this point. Stress, trauma, anxiety, ADHD. Good. What else? There's a couple more that are missing. ADHD, autism, anxiety, trauma, ODD, DMDD. Yep. So you all, we got ADHD, DMDD. You all got most of them. That was on my differential. Depression is the only one that was missing. Depression, ODD, anxiety. And then we're doing this presentation on trauma, so trauma is possibly one. So more on little Johnny. Little Johnny's anger is daily, almost all day, every day. He wakes up in a bad mood. He is always, quote, on edge, end quote, very, quote, jumpy, end quote. He says that he has nightmares of scary things which keep him from falling asleep, but he cannot describe what happens in the dream. Two months prior to this office visit, little Johnny witnessed a home invasion. Intruders entered their home, tied his mother up, and put a gun to her head in front of him. They also held him against the wall while they were stealing items. Does this change your differential at all? Wow, exactly. And that's the type of reaction I wanted you to say, because this shows the importance of asking about trauma at every mental health visit, as this could have easily seemed like ADHD, DMDD, ODD if we didn't probe about trauma. And this is obviously the patient's name is changed and some stuff is different, but this is actually a patient that I've seen in my office who was actually diagnosed with ADHD by the primary care provider, because the primary care provider never even asked about trauma at all, only went by the symptoms. And when I asked about trauma, I got that whole entire story of the home invasion. So again, it is very scary. A doctor never asked about trauma. Very scary, very scary. And this child was placed on stimulant medications, which obviously don't work for trauma. And so that's how they ended up getting a consult, getting referred to psychiatry, because the kid was not getting better with stimulants, because they thought that it was ADHD this whole entire time. Yeah, but this truly happened. So this again is why I want you all to have in the forefront of your mind to ask about trauma and not forget about that, because sometimes especially in your busy practices as primary care providers, you all can forget to think about trauma, and it can happen. It literally can happen. And so that's why I want it to be something that's in the forefront of your mind, that you get used to doing every time you see someone for a mental health visit, so that it's already second nature for you to ask this question and not miss these important details. So how can we help little Johnny now that we know this? So trauma-focused psychotherapies are considered first-line treatment for PTSD in children and adolescents. They are shown to be superior to non-specific therapies in resolving PTSD symptoms. And they must have the following components. They must directly address traumatic experience. They must include the parents in treatment. And oh my goodness, I'm so sorry that happened to you. Focus on symptom improvement and enhance functioning resiliency. And so the main trauma-focused therapy that we think about is trauma-focused CBT, or TFCBT, trauma-focused cognitive behavioral therapy. That has received the most empirical support for the treatment of childhood PTSD. Several randomized controlled trials show clinically significant improvement compared to community treatment, and components of that include a psychoeducation piece, a parenting skills piece, a relaxation skills piece, an affective modulation skills piece, cognitive coping and processing, trauma narrative, in vivo mastery of trauma reminders, and then enhancing future safety and development. So there's a whole protocol that goes with trauma-focused CBT. And sometimes we have to make sure, because some kids will say, yeah, I got this trauma history and I'm in therapy, but it's not helping. We need to make sure that we ask, are they in trauma-specific therapy? Because trauma-focused therapy, because that's the only way they're going to get better with their trauma histories, is trauma-focused therapy, not any other type of therapy. There's also a cognitive behavioral interventions for trauma in schools, which is the best research group CBT protocol for treatment of PTSD in children and adolescents. And it's very similar to trauma-focused CBT with a teacher component and an optional parent component. There is a seeking safety trauma-focused psychotherapy, which is a manualized group or individualized CBT therapeutic intervention for those with PTSD and comorbid substance use. And then there's eye movement desensitization and reprocessing, or EMDR, which is a type of trauma-focused therapy. And a meta-analysis from 2017 determined that children and adolescents treated with EMDR had a reduction of their trauma-associated symptoms as compared to controls. EMDR is actually really good for kids that don't like to talk, and that don't want to talk about their symptoms. They can do EMDR and still get adequate treatment, because it doesn't require a whole lot of talking with doing EMDR. So keep that in the forefront of your mind when thinking about that. But the clinical pearl about all of this is that psychological interventions are the mainstay of treatment in traumatized children and adult adolescents, not medications, as we will talk about here. So for pharmacotherapy, the data is insufficient to recommend pharmacologic treatments of PTSD for children and adolescents as first line. SSRIs can be considered for the treatment of PTSD in children and adolescents, but that's mostly because of data extrapolated from adult data. There has not been any data in children and adolescents that show SSRIs are helpful for PTSD in children. The current data suggests considering SSRI treatment if symptom severity or lack of response to psychotherapy occurs, but there is insufficient evidence to use SSRIs without psychotherapy. Also, if there is a comorbid psychiatric condition that we know is present, which is known to respond to SSRIs, like depression, anxiety, or OCD, then definitely use SSRIs earlier in their treatment rather than waiting for that to before you decide to use SSRI, if we know that there is a comorbid condition. And the clinical pearl with that is that some SSRIs are activated in children and can cause irritability, insomnia, and inattention, which are also symptoms of PTSD. So SSRIs may not be a good option for those younger children who have those symptoms. Just something to think about. Alpha and beta adrenergic blocking agents, so clonidine, guanfacine, propranolol, are okay to use in children and adolescents with PTSD because there is increased adrenergic tone and responsiveness in children with PTSD. And so those medications are helpful for decreasing that hyperarousal, impulsivity, and re-experiencing symptoms. I like to think of it as those medications are kind of dampening down their flight or flight response, which in turn improves some of the symptoms of PTSD. Basically, in short, the data for pharmacologic treatment of PTSD in children and adolescents is lacking. So therapy is the primary focus of treatment for children with PTSD. And I know that parents may try to bully us into prescribing different medications to address these behaviors, but we have to continue to explain to them that without the therapy, because sometimes parents want just only medication and don't want to go through the therapy piece. But we have to explain to them that without therapy, the medication is merely a Band-Aid. And while medications can help with some symptoms, the real treatment for children and adolescents with PTSD is therapy. Again, therapy, first and foremost. Here are my resources, and now any questions?
Thank you, Dr. Johnson. Excellent session as always. So I would like to open up the phone lines for anybody who's on the call today. Feel free to ask questions. Dr. Johnson, as a forensic psychiatrist, and obviously knows her trauma, and it's obvious that we are still learning in that primary care setting. Dr. Johnson, I'm going to watch the chat here. The little Johnny situation that you shared, I think should wake us all up to the situation and the concerns we have for trauma. And, you know, we need to, even though this is child psychiatry, we need to look at this in all aspects of our society as far as in family medicine, not just in pediatrics, in OB-GYN as well. Can you share a little bit about how you as a psychiatrist address these issues in psychiatry? Obviously, with trauma, it's assessment and getting them to good counseling. What else can you do? Because I think a lot of providers, when they call us at CPAN or they don't call, they think the answer is just, I need to send it to psychiatry. But you're telling us here that this is really a therapy treatment.
Yeah, and so because of the time that we have in psychiatry, we're able to do some of those techniques that are able to be utilized in trauma-focused CBT. And some of those things may not be able to be done in a 15-minute or even 30-minute primary care visit. However, talking about things, first of all, making sure that the kids are safe, and feel safe, and that they feel, and making sure that the offending agent of the trauma is not, they don't keep being re-traumatized, is one thing that primary care providers can do. But another thing is just talking about a few coping mechanisms. Even if you can't talk through the full trauma therapy, you can help the kids with coping mechanisms like progressive muscle relaxation, or deep breathing exercises, or talking about meditation, even using guided meditations. I tell patients a lot of times, hey, there's guided meditations on YouTube. Pull up a guided meditation video and do that to help them learn some coping skills that can help them feel better. So while in a primary care practice, you may not feel like you have the time to go through and address the trauma individually, but you can at least help them with some coping mechanisms when they feel that increase in their body, that physiological reaction that they have from trauma. They can at least try to address it in some kind of way with some coping skills.
And if a provider is not sure if it's trauma or ADHD and they've done their screening, they can actually contact CPAN and get an assessment done, a one-time full psych assessment done, can't they, Dr. Johnson?
Yes, that can be done easily. And then the psychiatrist, the child psychiatrist, whoever does that evaluation, can walk you through and talk you through exactly how to go through treatment and how to address the issues. But a lot of times, we see with this that when primary care providers get this type of question, they, automatically think that throwing a medicine is going to fix the problem, throwing a medicine that is going to fix that problem. And doing the CPAN direct consult and talking through the case, you actually learn that they may not be the most efficacious treatment option.
Thank you. And it looks like Dr. Marin has a question. Dr. Marin, go ahead and unmute yourself, please.
Hi, sorry to keep you. I'm sure people have to leave, but I just have a question and concern. Is that most of the patients I see, I work with very underserved populations in Tyler, and I would say most of the patients I see and I treat for mental health do have, symptoms of trauma, and I'm thinking about that and I'm asking about that. But there's a lot of them that don't have the best family situation even as we speak. So it's hard to say, oh, I'm just going to do therapy or we're going to work on these things. So a lot of them are on medicine because I just don't know what else to do. And sometimes I do consult with CPAN, but it's so many of them that it's overwhelming at times. And I think we do prescribe a lot of medicine that is not necessarily 100% necessary, but sometimes it's the best you can do, at least temporarily.
Yeah, unfortunately, that is the case with a lot of, especially what we deal with in our area, with our lack of resources in the area. Like you said, the home environment is not the best, and it contributes to, and basically the child is being re-traumatized, every time they walk back in their door from school. And so, yeah, sometimes all you can do is do the band-aid of medication. And so, sometimes that's the best option that you have. It's just, for us to know as providers, like, yes, we can do that, but understand that that's merely a band-aid, and, we have to try to get other things in place to help improve the situation. That this it's not going to be, it's not fixing the problem. It's just merely a band-aid. And so just understanding that when we're doing that, not to say that you can't do it at all, because we all do that. We all get to a point to where we have to utilize something, because again, we can't. A lot of times I jokingly say, a lot of times some of these kids need a parentectomy. And if we just take them, just cut them from their parents, they will improve significantly. But we can't do that realistically. And so, sometimes all we have is to utilize medication until the therapy starts to take place. But just understanding that the medication, the key piece is understanding the medication is not solving the problem. It's just helping. It's just a means to an end for the moment. It's just helping for the moment.
Thank you for that great question, Dr. Marin. And also, CPAN can help you find resources. There are resources and referrals out there. CPAN can do that. We vet those. They're back to you within 24 hours, even if that patient has Medicaid. Also available, if that trauma is pretty significant, Dr. Johnson, we can also do an intensive outpatient option. And there are those services available as well, even for Medicaid. The direct consult that Dr. Johnson was talking about can be completed actually within 2 weeks. If your typical response to a mental health need is to send that patient to a child psychiatrist, if you're in Northeast Texas, it's going to take 8 to 12 months for that kiddo to be seen if they're a new patient. And then that interim time, that patient and that family is suffering. So that's why CPAN exists. That's why we're here. And we are here to support you and serve you through the expertise of child psychiatry. And that's a comment from Dr. Davis. Do you see it, Dr. Johnson?
So, yes, I do see that question from Dr. Davis. So because of the questions that the pearls ask, I look to see which questions. So it's not necessarily a number, but it's which questions are the positive ones that I would give the CPSS-5 to them. Now, sometimes I'll just, if they have a positive pearls period, and then when I'm looking at their chief complaint for why they're showing up, sometimes I'll just give the CPSS-5 anyway, because I'm like, something isn't right here. Let me just give this. And then with my questioning, once they come in my office, I'll do, more assessment and asking questions. Have they had trauma? And then utilize the score from the CPSS-5 after that when I see a positive pearl screen. So it's not necessarily a number, but more so what behaviors are they, what's in their chief complaint, and the severity of that when they're coming to see me will determine if I decide to give them a CPSS-5 or not. And then also which pearl screen questions are positive, because it's the pearl screener is 2 pages. So when I look and see which questions, and those with the big T traumas, I definitely give a CPSS-5 to. and then it depends on the number of the little T traumas that I was talking about. Depends on if I'll give a CPSS-5 to or not. But the CPSS-5 also has its own screener attached to it, so you don't even have to use the pearls. If you want to just give the CPSS-5, there is a screener on the first page of that, and then if they're positive, you can give the remainder of the CPSS-5 from that.
And as a reminder, I put in the chat earlier that you can get those screening tools from your local CPAN. Just contact your CPAN team and they will get that sent out to you and you can make copies of that. That's all been provided for you. And then if we actually receive a request for a direct consultation and there's a potential for trauma as a diagnosis, those are actually sent out to the families to complete as well. Any other questions? Again, excellent session, Dr. Johnson. I appreciate you so much. Go ahead, question.
I'm so sorry. I have a quick question. I know this, trauma involves like the whole family, and how, I guess, if the parents are actually the, the people doing the trauma to the patients, and you're actually interviewing them, what is the best way, I guess, to, I guess just, interviewing the child by themselves, or how would you, suggest that?
So
the parents are a barrier.
Yes, so I typically will interview the child by themselves to get the information, and then if that's the concern that the parents are the perpetrators, I'm also calling CPS, Child Protective Services. I'm doing a complaint with them as well. But yeah, I will ask for the kid to be seen by themselves, and so I'll say something like, there's some questions that I want to ask that usually, kids are not comfortable with answering in front of their parents. So if you could please step out or, go back to the waiting room or whatever, I will come back and get you once I'm finished asking those questions. I usually put it like that so they can't figure out what I'm getting ready to ask or what I'm going to talk about. And I just put it in a very general sense.
Okay, thank you.
Welcome.
Great question. All right. Thank you, Dr. Johnson. Really appreciate your time today. Thank you all for joining us and even staying over a little bit. Next month, we have Recognizing and Reporting Child Abuse, which will be held on November 11th. Our friends at UTMB in Galveston will be facilitating that session, and we're hoping that you can join us for that. Again, thank you for joining us from CPAN CME here at UT Tyler Health Science Center. Have a fantastic day. Bye now.